Now in this session, the last lecture is delayed presentations in proximal tibia fracture, how to optimize the outcome. Dr. Harpal Sethi, please.
Good morning once again. It's again a topic I have found it hard what to include, what not to include in this. It's a very vast thing. At the outset, let me clarify, I'm not a Ilizarov surgeon. I'm a trauma surgeon who just does some Ilizarov in trauma cases. So why the delay? Normally what we face in our day-to-day life, why we see delayed cases is sometimes, nowadays very rarely, is because of neglect. Some patients will have compartment syndrome and we have to electively delay them. When they come for surgery, some of them are non-operative mismanagement. The reason I write mismanagement is non-operative treatment is very well part of the protocol of these patients, but some of them, if not managed properly or are not indicated to be managed non-operatively, I'll call them as mismanaged cases. Some get delayed because of associated injuries and some because they are open fractures, and for definitive fixation we have to delay them. Last of all but not the least is vascular injuries, where you do a vascular repair. You don't fix them primarily on day one. You wait for the limb survival and then go ahead. So what are the challenges? First is the soft tissue envelope is compromised in these patients. There's a lot of fibrosis by the time you go in, and most of the times there is early callus formation already there when you approach the bone. So the manipulation of the fragments becomes very difficult in these patients. First case, 55-year male, head injury, polytrauma, had a compartment syndrome. Tibia was closed, other side was fixed, forearm was fixed. On this side, because of compartment syndrome, the wound healing, the muscle necrosis, we had to wait. And by the time we could do it, it was 3 months down the line. So I was afraid to go in and acutely manipulate these fragments. In this scenario, Ilizarov works very well. You can just apply in situ Ilizarov, maintaining the alignment of the limb, which was possible, and then you can compress using the Ilizarov two fragments together by manipulation in the translation device. This goes on to unite very well and without any complications. I didn't touch the soft tissues, didn't open up, so that gives me a good result. 26-year male, open fracture, came to the emergency. We managed with the spanning X-fix. Again, by the time we could take him in to the theatre for definitive, it was too old. Put in a Ilizarov, compressed it, nicely goes on to union. He is due for removal of his fixator now. Now this is a case, young male, 42-year-old, comes with a bullet injury. Vascular injury, the vessels are not palpable. He's presented after 6 hours, but the foot is warm, some sensations are there. The plastic surgeon refuses to revascularize the limb. He says we'll just observe, but they go ahead and do a fasciotomy on either side. Now what do we do in such a patient? So I went ahead and did a spanning X-fix, didn't have any other choice. The fracture is not much displaced and the alignments are good. Same is held in the spanning X-fix. 7 days down the line, the limb is surviving, foot is warm, sensations are preserved. I wouldn't like to go ahead and do an internal fixation, don't want to compromise already compromised vascularity. Plus the fasciotomy wounds have been open for 5 days. Went ahead, did a Ilizarov. The callus formation can be seen now and it's going on for union. 42-year male, 8-month-old, simple fracture which was fixed. I don't have the index X-ray. Fixed at another center. The implants have gone loose. He got the plate removed The infection is silent. What do we do now after 8 months? There's a lot of fibrosis. That's my personal choice. I prefer not to open these up. Again, Alizarov acute compression made him walk, goes on to union. He's again due for removal. Alizarov is not the only choice here. I'll finish off the talk with, again, the same patient, 75-year male I showed in the distal femur. Now he's in the proximal tibia group. He had same fractures. Again with the Alizarov, goes on to give a good union, a nice callus. Last case, young patient had a medial condyle fracture which extended down into the shaft. This is not my case, it's from a friend, Jignesh Pandya. Was fixed by one of his colleagues. Dual plating, posteromedial plate and a medial plate. Nice reduction. Few weeks down the line, it showed varus collapse and collapse of the fragment. Probably wasn't buttressed that well as it was required. Was reoperated again. Elevation of the fragment, proper posterior plating, proper medial buttress, and a lag screw. So, you as a trauma surgeon, when you have neglected cases or you have delayed cases, you cannot be focused on one modality. You have to be well versed with all modalities, what will be the best for the patient. For intra-articular steps like these, you need what is required is internal fixation. Wherever it is possible or internal fixation is not possible or not desirable, you should have a backup plan with you. So that's why I say let's be gardeners. I just can't keep stressing, there's never be more on this or is excess. We have to learn that the roots of the bone are in the soft tissues and we have to preserve the soft tissues. Thank you again once again.
Thank you very much, sir.